Okay, we're going to get started in like 30 seconds. We have about 19 participants. Kick it off on this bright Friday morning, bright wherever you are. It's bright because we have a bright set of panelists. That's my Friday morning joke. All right, so let's get started. See a good chunk of people, a lot of fun, good-looking people as well. So let's get rolling. Give me 1 second, just one logistics. All right, so let's get started. So thank you to all of you for joining us on this Friday morning. I know it's early, but this is a fun topic, so I'm assuming that that's the reason why you all are here. The series that we've organized, the format that we have is because it's the year of 2021. It's a virtual panel, but in 2021, this company Clubhouse has become sort of quite popular. So I think of it as Clubhouse in the morning with video. I used that last time as well, but that's how I'm thinking about it. So I'm your host today, Sudipto Srivastava. I'm super excited. It's an exciting topic that we're going to be talking about. So today we'll focus and talk about and hear from our panelists on like TeleHealth 2.0, like looking ahead. As we posted online, telehealth finally had its moment in 2021. I was sort of joking with Nick earlier that since I think we tracked it back to 2011, when people were saying, "Oh, this is going to be the year of telehealth. This is going to be the year of telehealth," and now here we are. Of course, it took a pandemic, unfortunately, but 2020 and 2021 really became the year of telehealth. But what we saw was, people we were fairly lazy in implementing telehealth. Basically, Zoom-ifyed telehealth by you want to have a visit with your doctor. Well, now you can have it via video, and that's it. There was nothing else sort of added to it. So I think it's time for TeleHealth 2.0, and who best better to discuss it than the panel that we have. And now I'm going to make an assumption that everyone knows what telehealth is or has at least Googled it before the session, so I won't bore you with definitions and so on, because that can take time as well. So let's start by first meeting a panel. We will go in alphabetical order. So we'll start with Dr. Darrow, then with Dr. Jeans, and then with Dr. Romm. You heard it right. All three doctors: one cardiologist, one a pediatrician, one emergency medicine doctor. And let's take it from there.
Very good. Thank you, Sudipto. Welcome to all who are here and to my colleagues on the panel. My name is Bruce Darrow. I'm a cardiologist at Mount Sinai Hospital in New York City. That's Grand Central Station outside my window. And I've been at Mount Sinai since 2000. And for the past 9 years, I've been Chief Medical Information Officer and now Deputy Chief Information Officer as well. And I get to work with great people to bring technology to patient care.
Thank you. And I am Nicholas Jeans, and I work for Bruce. I am an emergency physician at Mount Sinai in New York. And last year I found myself as medical director for our virtual urgent care at Mount Sinai, which had been a kind of little corner of the institution that didn't see a lot of attention or a lot of use. We went from a handful of calls per day to when the pandemic hit, hundreds of calls per day. And so we really had to ramp up our staffing and our protocols to kind of meet the surge and meet the patients where they are. I also serve under Bruce as Associate CMIO at Mount Sinai.
Morning, everyone. My name is Sylvia Romm. I'm a pediatrician. And I have to actually do a quick story, Sudipto, talking about this being like the video version of Clubhouse. When my son was 8, he saw an encyclopedia for the first time and was like, Mom, what's that? I'm like, well, it's like if you took Wikipedia and you put it into books. And he was like, oh, is that where encyclopedia comes from? So, it's all about your perspective. But yeah, so I'm a pediatrician. I've sort of bounced back and forth between the health system space and the digital health space and industry. Having been in the Mass General Brigham system for a while and then came over to American Well, was Chief Innovation Officer at Atlantic Health System in Northern New Jersey. And I'm now Chief Health Officer of Virtual Care at Cityblock Health, which is a value-based organization that takes capitated payments for low-income and older Americans and then provides holistic care for them to bring better health outcomes at lower cost, which we'll talk about a little bit later, is great for digital health because a lot of what digital health does is connects people in easier and better ways, which usually drives a lot of value in healthcare. And so bringing that to value-based organizations is a really natural fit.
Cool. Well, thank you all. It's definitely a pleasure and honor to have all of you. I've had a chance and to work with all of you as well. So this is super cool. It's like a meeting of friends as well, kind of like Clubhouse, right? But so let's get sort of started. There's a few questions that I want us to go through and get all your inputs on. So maybe let's start with a broader one. Like what are we not doing with telehealth that we should be? And we'll go in alphabetical order, and then we'll sort of keep switching that around. So Bruce, we'll start with you. Nick, then we'll hear from you, and Sylvia, then from you. Like, what are we not doing with telehealth that we just should be?
So, and I'm interested to hear what my colleagues have to say about this because our clinical perspectives are so different. Whenever there's a new technology out there that takes the place of whatever we were doing for an old process, we're really bound by our knowledge and experience of the process the way we did it before. And so we take our technology and we try to fit the old process in it. So for example, if I said, okay, I need something that's kind of like a car that's going to get me from one place to another, why don't you draw something up that would do that? Chances are you would build something or draw something up that has 4 wheels. Why not 3? Why not 6? So I think what we've been doing with telehealth, especially in the last year where people had to go so quickly from office-based visits to virtual visits, is we said, okay, how am I going to use this technology to do the same things that I was doing when I was in the office? Asking the same kind of questions, documenting the same kind of stuff, and not yet getting to the point where we change our processes or practices to take advantage of the things that are out there. And yes, it will take technology and a lot of groundwork to do things like say, okay, on my telehealth visit with my patient, I'm going to be able to integrate the information from their blood pressure cuff, and not every one of my patients is going to have a blood pressure cuff, let alone one that will integrate. But even things like, if I were a shoulder surgeon, for somebody who was coming in the office, I would do this. I would make them move their shoulder around and I would feel it. For somebody who is on the telephone, I would ask them, so how well are you moving your shoulder? For somebody on video, I could watch them do this, but over time, I might find standard ways to make it more valuable. Like say, okay, when you come for your video visit, make sure that you have a can of soup with you. And then I'll watch and see how well you do lifting that can of soup. And so I think what's missing from telehealth at this point is the kind of experience that will let us as clinicians make it more valuable than just having a phone call with a face on
it. Yeah, Bruce, I think you're right. It is a subtle point when I'm training our residents for, using telehealth and getting an effective clinical exam at a telehealth. I want to emphasize to them that you can actually do more than you might think with telehealth. You can coach patients through a self-exam. You can, there's nice ways to teach them to take their pulse, or to even do like a ankle exam, shoulder exam, etc. Especially if they have someone else in the home with them, they can do all kinds of neurologic things, palpate the abdomen and so forth. So I don't think of it as like a purely limited medium, but or at least it's surprising how much you can get out of it. But with technology that we're enjoying today, I wish we could do so much more. I think back to last spring, as we were starting to get a lot of COVID patients, and some had COVID and they were worried, are they getting sicker? And we were trying to figure out, are they truly hypoxic? Are they hypoxic with exertion? We were fortunate, a lot of people were calling in with their smartphones, so we could actually have them walk and talk like those Aaron Sorkin shows. And we could see, like, does a little bit of exertion cause them to get very winded, like they can no longer tell a story? And there was something called the Roth score that was never really that well validated, but just having the patient count out as long as they could in a single breath, and then finding where they got winded, may be a measure of hypoxia. But and this was a time where pulse oximeters were in short supply, when the devices and technology just weren't there. I kind of can't help but think that in a few years, our smartphones, our sensors, our watches are going to be a little bit further along, to the point where we can really leverage them for just even collecting vital signs. I'm reminded there was an app on iOS. I searched for it just before our call. It's not there anymore, but it was called Philips Vital Sign Camera. You can Google it. There were press releases about it, because it was actually using the iPhone camera to detect subtle variations in your cheeks, in the color of your cheeks. And it would say, like, oh, that is the beat-to-beat variation of your heart. And so it would actually estimate your heart rate just by looking at your face on camera. And this was in 2012. And now I think all the patients that were calling in to telemedicine with their iPhones, and we weren't even trying to make use of that kind of extra rich data that's lurking just below the surface. So lost opportunity.
Yeah, I just, want to piggyback off of that. When I was at Amwell, we had a company come to us, and for various reasons, it didn't make sense for us to work with them. But this is a company that had been spun out of an academic medical center by a couple of intensivists who did just that. They showed that you can take data from a video feed, so you don't even need like devices in the person's home. The analysis is on the side of where the video feed is coming into. Like they even showed us that you could do a video of a video, and what they did in the demo was they did a video of a phone taking a video of me, and I had a pulse ox on, and they were comparing it with the heart rate and the O2 sat of the reading on the video. And it was accurate with everybody that we tried in the room. And this is like 3 years ago. And I was just like, oh my gosh, the fact that we don't have this technology ubiquitous, because it's not about the patient. The barrier is not coming from the patient side. The barrier is coming from our side. Why haven't we implemented this technology everywhere? Just shows that we've really only scratched the surface of what it means. Even in a pivot and a pandemic to go into doing telemedicine, we still have barely set up the infrastructure to be able to utilize what we're doing. I think that once we get now that we've gotten to the point where we've set up kind of poor UI systems for patients and providers to connect with one another, we're like, oh yeah, look at how much better our telemedicine infrastructure is. But I mean, imagine if Amazon had said, okay, well, now instead of going into a store, you can like set up an appointment that you have to like do 15 different data checks to get into. And then you can wait 20 minutes and talk to somebody at Amazon, and then you can order something, and like, yay, we have a great new technology customer experience. That's kind of where we are right now in healthcare. If you think about it, we've taken a system that has historically not had a great patient experience, made it like a little bit better. And we're like, done. It's the year of telemedicine. There's a lot that we can do there. I just wanted to quickly answer Jeff's question. Cityblock's model is very similar to Oak Street and ChenMed, but whereas Oak Street and ChenMed focus on Medicare Advantage, we do have some Medicare Advantage, but we primarily focus on managed Medicaid and duals. And so we're really looking, yes, certainly older Americans, and there are lots of older Americans who are also lower income, but really our focus is on lower income. And then just to, if sort of taking the intersection of those two, the Venn diagram of serving lower incomes Americans and what aren't we doing with technology, we still have a lot of barriers to utilizing technology for people who are lower income and maybe older. And there are lots of ways that you can get around that. First of all, like I said, a lot of our user interface, like user experience, not to use too much jargon, it's just not easy. It's not simple. And so if you don't have high levels of tech literacy, if you're not well-versed, if maybe you have other barriers, it's really, really hard for most people to use the technology that we've given them. And what's interesting is that a lot of people think that like the physical technology is one of the biggest barriers. And being in a group that serves lower income Americans, it's not the ownership of a smartphone that is the greatest barrier. It's the data, the bandwidth, the cellular data, the tech literacy that uses that. That's really the huge barrier. And so we're getting around that by doing really creative things like doing hybrid visits and sending people into the home to bring the technology with them. There are added advantages to that as well, including being able to get vitals and labs and things like that. So for a capitated payment, it makes sense. But really looking at using technology to reach everybody and improve the healthcare of everybody.
That's awesome. And thanks, Sylvia, for keeping, you're such a pro, you're keeping track of the questions and everything else and so on. So we'll take a pause and see if there's any questions from the audience, and, you can certainly post it, because, I have a few questions that I want to ask our sort of panel speakers, but it's best if some of the thoughts come from you. So Shannon is asking, I'm curious about telehealth and digital health overlap and distinctions. What are your perspectives on remote care opportunities beyond videos or telephone modalities such as asynchronous communication, texting, RPM, etc.? How are current billing and reimbursement policy impacting their proliferation? Wonderful question. And we actually, Shannon, just to put a teaser out there, on May 14th, we're going to have a session just dedicated on RPM, and we're going to have some amazing, equally amazing sort of speakers. But we'll take a quick sort of crack at that right now. So we'll go in the same order. So now we'll go with Nick, Sylvia, and Bruce, whatever your thoughts to Shannon's question might be.
It's a great question, and I think maybe to outsiders especially, it's surprising just how much the reimbursement model dictates the programs and plans that move forward. I think especially after the pandemic, a lot of hospitals are a little cagier about making big investments and waiting years to see a return on those investments. So, if they're going to be implementing new technology, they really need to be careful about it, and they need to make sure that it starts to pay for itself sooner, rather than waiting a year or 2 years, or waiting for like adoption to really take off. So, we do have some neat remote patient monitoring programs for diabetes, blood pressure, pulse oximetry for COPD. And the technology is kind of cool, like it's about what you would expect. But so much of what gets implemented and what gets rolled out is actually really dependent on like a fine parsing of the language of the CMS rule for reimbursement. Going down to like, the number of data readings that you have to accept within a 30-day period to be able to successfully bill for it, whether the device is, connected directly to like from Bluetooth to a hub to the doctor, or whether it's just, handwritten. These things are all spelled out in the federal regulations, and it ends up impacting everything about the how the technology is used. It is kind of surprising.
Cool. Sylvia, Bruce, anything to add to Nick?
Yeah, no, I agree. Again, one of the things that's really great and interesting about working in a value-based environment that's not fee-for-service based is that we don't need to contort ourselves around these rules and thinking about what we do. I mean, it's not completely divorced from that. We certainly have some requirements and how we think about it, but by and large, as a physician working in an environment where really when you create a program, the question is, are we improving the health outcomes of our members? Are we doing it at lower cost? Okay, great, go. It's such a freeing thing. And especially, being, I've been using telehealth for a really long time, and I run a bunch of groups for physicians in telemedicine. And it's really disheartening to me to see the percentages of conversations that are around, regulatory and billing questions versus the percentage of questions that are around, hey, how do we improve the protocol for hypertension by using technology to communicate with our patients in different ways? And I really feel like that's a huge missed opportunity for our country when you think about the people who are looking at regulatory environment and reimbursement environment and are supposed to be driving better health for Americans, for our fellow countrymates. And instead what you're doing is, driving administrative bloat by basically having people hire more people to understand the regulations and then having it fight back and forth. And so, really getting down to this, capitated environment style, I think would be very, very good on both sides, honestly.
Awesome.
I think Sylvia's point about the influence of billing and finance on telehealth it's hard to overstate that. That's tremendous. And one of the things that's always been tricky for me is when we use the term telehealth, people immediately think of video visits. And I think that is frankly a problem. When I think of my phone and the way I communicate with people on my phone, I don't think about video calls as the primary way of communicating with people. I think about texting, I think about asynchronous communication, I think about the message I send that somebody's going to see when they get a chance later on, not right that moment, whereas video is really conducive to in your face, this has to happen right now. Both of us are concentrating on the screen in front of us, and it really limits, and that's why in general, I think the term virtual care is a little bit more inclusive. And, all of this stems from billing. Clinicians historically only got paid to take care of people that they could touch. If they were in the hospital, if they were in an emergency room, if they were in an office. And for anything else, you didn't get paid. And then they said, okay, we'll let you pay, but we're going to make it so that it has to be under these circumstances. It has to be video, and it has to be face-to-face, and it has to be real, or real time. And it can only be for certain diagnoses like behavioral health or whatever, and every time they say, well, we're going to let you take care of your patient, but we're going to stipulate how it's going to be, that puts artificiality into the process. So I think all of these, as you loosen the ability to do your job, take care of patients as well as possible, to Sylvia's point, with all the technologies, you'll see them emerge.
Super awesome. Keep coming with those questions, folks. And Josh, it's quite nostalgic to sort of see you going through the subway system of New York City and Brooklyn in the top. So that's adding color to it. So I want to, go with sort of another question, like almost like future looking, more from a technology and innovation perspective. So, what innovations are you seeing in the industry that actually give you hope that we will move away from all the lazy ways of, implementing and doing telehealth that, we've been sort of talking about? Sylvia, I'll start with you, and then we'll go to Bruce and Nick in that order.
Yeah, I mean, I think there are a bunch of different forces that are converging upon healthcare at the same time. That is, uh, you know, really encouraging this change in an industry that, for very good reasons, has been historically pretty conservative about change. It's like when you make changes in healthcare, it's impacting people's life, it's impacting people's health, and so you want to evaluate them and you want to move them forward. On the other hand, if you move too slowly, then you're also hurting people, because if you're not taking new advances on that could save people's lives, your baseline has shifted, and so like you are now no longer doing the most that you could be doing for your patients. And so how do you balance that? Not doing too many things that are untested, on the other hand, like not leaving good things behind because you're worried that there's not RCTs for everything. And so what you see in healthcare is that you have these disruptors that are coming in, that are looking at healthcare differently. And so, part of my role as Chief Innovation Officer at Atlantic in the health system space was to look at, non-traditional competitors. Often for health systems, you would look not just at other health systems, but even health systems that were geographically located close to you. And so when you were looking at, whatever, let's pick something random, like online scheduling, it's like, oh, okay, so what are other health systems in a 500-mile radius doing for online scheduling, right? And then like that would be your view of what it means to be competitive or like cutting edge. But I think people are realizing like, gosh, Amazon Care is going to be a competitor. Walmart is going to be a competitor. And so those forces are making traditional healthcare systems think differently about what it means to be convenient, what it means to be accessible, what it means to be safe and build trust with people around them, so that people will keep coming back and getting care. And so I think those forces are definitely pushing things. And on the other side, you have big tech, which has historically kind of stayed out of the healthcare space, or usually they come in, they try, and they go, whoa, this is really hard, and then kind of back out of it again. But big tech is starting to say, hey, look, we, with our data analytics, we can start predicting when people are going to get sick, and we can start treating people earlier and having better health outcomes. Sorry, kids here that are coming in and out. Welcome to the pandemic. But everybody is going to have to follow suit when they do that, because at that point they'll be providing, have the ability to provide different kind and sometimes better care than what we're doing traditionally.
Yeah, I love it, Sylvia. I almost expect you to go like the famous video, like push that sort of kid down, and I expect to see your husband running from the other sort of room, like trying to grab him and go.
Again, like we're all kind of used to it now, right?
We are. This is great. Bruce, your thoughts?
Sure. People like cool things, and it doesn't matter what the circumstance is. And people will see something. They'll come in and say, "Hey, I saw something on a news program the other day about some technology that allows my doctor to know if I'm depressed based on whether I'm texting people more frequently or less frequently than I used to." Or I saw a billboard that shows that the competing hospital system across town is doing this cool thing. There is a lot of pressure to be cutting edge. When you ask patients what factors they consider when picking a practice, the idea that they're using new technology or cutting edge technology sometimes is rated higher than their ability to provide quality care, surprisingly enough. And so I think that there are going to be obvious and natural pressures to do more.
Nick?
Yeah, I think a lot of potential here. Also, a lot of potential for false positives, or unnecessary or avoidable visits or healthcare expenditures. I'm reminded of we had a colleague that said, like, look, I got sick on Friday and there was a signal in my step count data on Thursday. Normally I hit 10,000 steps without even thinking about it, but the day before I got sick, I only did 7,000 steps. It was probably because I was starting to get under the weather and conserve energy and so forth. And I was like, if you had shown up in my emergency department on Thursday and said, I didn't walk as many steps today, I think I'm coming down with something, it's nothing for me to really act on. I could spend a lot of money and test get an x-ray, get urine studies, etc. And might find something, probably wouldn't find anything. And then where would we be? And this was a minor illness that got better on its own anyway. So a lot of times detecting that signal, it's fraught with its own risks. Having said that, I am still a big fan of technology, especially when it's properly studied and evaluated. And gosh, we were looking at this a few months ago. There are these voice analysis systems that are looking like, look, I went to med school 20 years ago now. We didn't have all these terms for like jitter and shimmer and like things about your vocal cord harmonics, the fundamental frequency of vocal cord vibration and things like that. No idea about any of this. Maybe some ear, nose, and throat specialists kind of can speak to some of this, but the point is that as you get sick, whether it's COVID-19 or Alzheimer's or Parkinson's, there are these characteristic ways that your vocal cords change their vibrations, and it can be picked up on modern sensors. And of course, it's not yet really validated, but like you could imagine as part of your future telehealth checkups that you are giving a voice sample, or that maybe you're doing some kind of movement tests with your fingers or something. And this is just part of your digital remote checkup. And it will tell the healthcare systems, tell your doctors a lot more about your health than what we're currently doing with this simple AV communication.
Interesting. Tons happening in that space. And I was equally excited about things the last 6-7 years tracking telehealth, but I'm even more excited, especially sort of the non-traditional players sort of coming in and trying to break things while the traditional system trying to force it, the regulators and so on. It's going to be an interesting medley of so many things, and who knows what comes out. And I expect Bitcoin to be launched on telehealth very soon, because that's the new cool thing. Like everybody's into Bitcoins. So Josh, you messaged me directly on a question, but I'll read it out to the panel because I think it's an interesting one. So Josh is asking to the panelists, like, I'm curious about the assumption that telehealth is hard to use. Every generation, by definition, as they grow, the telehealth aspects should get more easier, more intuitive, collect better data. So do the panelists see this problem going away at some point? I guess, what you're saying is, the older population will sort of age out and the younger population will coming in, and there'll be a heavier use of these kinds of tools and so on that happens. So is there a tipping inflection point in 2 to 5 years when this concern becomes a non-factor? So I'd love to get your thoughts, and especially sort of Nick, maybe you can talk in the context of one of our favorite companies from 6-8 years ago, Sherpa, that went, like, it was very early in its time, got acquired and everything else. And then now the founder has sort of left and so on. So, we don't have to sort of start there, but would love to get the panelists sort of view. I'm kind of losing track of, who goes, but maybe Bruce, we hear from you, then from Nick, and then Sylvia from you.
Yeah, I remember Sherpa, and it was an interesting model. It was really a virtual clinic where there was no expectation that the doctors would ever see the patients in person, and anything that required escalation to either an in-person visit or hospitalization or something like that was coordinated. But the bulk of the care was given virtually. And not by video either, but mostly by phone or asynchronous. So, and I think that model works, and I do think we're going to see that, in the same way that the primary care doctors and office doctors said it's, we're gonna give up the vaccination business. This is before COVID. We're gonna give up the flu vaccine business to the pharmacies. Maybe it's not quite the same, Sylvia, in the pediatrics world, but for adults, I don't know that many people who go to their doctor to get their flu shot these days compared to the number of people who go to the pharmacy to get it. I think you're going to see more and more of the easier, less acute, but very responsive to good communication portion of care be siphoned off from the big healthcare systems. Somebody doesn't care if I am, Castle Connolly and an expert on advanced heart valve disease, when all they want to know is whether or not they need to adjust their blood pressure medication. Somebody who answers their texts or their calls right away is going to be much more valuable to that patient than somebody who is, on the lecture circuit. So I do think that model is going to find its home primarily with those patients.
Nick, your thoughts?
Oh, yeah. You're right. And I was just, so Jay Parkinson was the founder of Sherpa, and he has a blog and he has a Twitter account. And so I like to kind of check in with him and see what his thoughts are. And he was probably ahead of his time, and he has some musings now. I think he went over to Crossover Health and then is now on sabbatical or something like that. But the point is, he's saying that like change is slow in technology, it's super slow in healthcare. And, now he's kind of seeing the investments pour into similar companies to what he had conceived of 10, 12 years ago. It's, maybe causing him some feelings, but that's the nature of how slow things move here. Doctors, hospitals, practices, very conservative when it comes to new technology. We've talked about, the reimbursement model, and some of that is unfortunately a big driver for a lot of it. But these are busy doctors that, have to go one patient after another, and they can't spend a couple minutes doing tech support for each patient that they're trying to do telehealth with. That's why they kind of minimize the number of bells and whistles that are happening, and it's got to be just the fundamentals, and it's got to work every time, because there's so many different points of failure with so many different kinds of patients. And I think that is what has kind of been limiting the field a little bit. I'm always struck by when you watch old TV or movies from the 70s or 80s, like don't judge, but like The Exorcist, for instance, when they needed to go get like high tech, figure out what's going on, they went to the hospital. They didn't go to like a research facility or, a fancy lab or anything. There was like, the hospital has what we need. Consumer tech has so exploded and so kind of lapped what these doctors' offices and hospitals have. Like the average age of a computer in a hospital is probably much older than what you have in your own apartment or home right now. So it's just sometimes the nature of the business that it's just going to be very slow.
Sylvia, your thoughts?
Yeah, it's actually, so one of the things I want to talk about actually is a comment on the prior point that Bruce was making, and Nick were actually you both were talking about data coming in, and instead of being useful to the clinician, to the physician, being overwhelming. You were talking about, oh, okay, you can talk about step counts going down, but what am I going to do with that data? I've internally coined this as something I call data fatigue. That as a physician, especially, so I was a hospitalist, and so like I kind of had shifts, and I had like limited patient data in a way. But if you're a primary care doc, you have an entire panel of people that you have to be looking over, and data is coming in there constantly. And I was talking to one of my friends at a large health system, and she said at any given time they have 100,000 resulted labs that nobody's looked at. And it's just, and that's traditional data, right? Where you send a lab out to somebody, let alone, newer data that's coming in. And so, I think that the next era of working with patients and understanding data is going to be getting information out of that data, so that we are going to be better clinicians. We're going to be able to build better relationships. And we're going to be much more proactive about how we care for somebody. Because you're right, like right now, if somebody has a lowering in step counts, you can run all the traditional tests, but all of our protocols are based upon people being sick, right? Like you have to get sick for us to do something. And so the idea that you can get some of these warning signs and keep people from getting sick is like something that we practically don't do in medicine. And to link that around with some of the the questions about where are people going for information, where do people put trust in healthcare? I think that the wellness industry gets a little bit of a bad rep in medicine for good reasons. I think sometimes there's not as much science behind what the wellness industry does, and so there's a little bit of controversy about people looking to them as healthcare sources of truth. But I think that there's a lot that in the traditional healthcare system, a lot that we can learn, not about how they get their information, the evidence base, but how they're presenting their information and how they're interacting with people, because they're really spending a lot of time building relationships and building trust. And I think that we still sort of come from an era of like, I'm a doctor, like you should trust me. And people, that's not resonating with people as much anymore. They're saying like, well, hey, if you want me to trust you, why don't you respond to my messages? Why don't you like try to build more of a relationship instead of, just dropping information on me, and then hoping that I do it. And so, it's like, how do we use the technology and, other forms of communication that have been so successful in other industries and adjacent industries, and apply the same like rigorous evidence base to the content behind it, so we can really reach people, really connect, and then bring them the evidence-based treatment and outcomes for both prevention and cure, when we think about providing whole person wellness.
Awesome, thank you. So keep the questions coming. Well, I will queue up sort of another question that I had in my mind. It's more focused on, say, entrepreneurs that might be in the crowd. And as I'm sort of queuing that up, we'll put out a poll, just get your feedback for how things are going, and I'll request the producers to sort of put that out. So take a few seconds sort of answering on that. But in the meanwhile, I'll ask the question, which is, if you were an entrepreneur, like, do you imagine sort of a future where the tech savvy platforms will do all things sort of telehealth? And and I define telehealth as what Bruce said, it just doesn't have to be video, it could be everything else. And the traditional systems, like the hospitals and the doctor's offices, they'll be relegated down to just the key things that you need physical interaction with, like the ERs, the ORs, and the ICUs, right? And that's where it sort of ends, and everything else has been disintermediated out in the field. So and that's, I'd like to get the panelists' perspectives on that, and also sort of think about where this innovation will come from. Do you feel that it's going to come from startups? Like VCs are pulling in so much money. Like back to Sherpa's point, he raised $12 million 15 years ago, and he probably had to give his firstborn away. And now you can get $150 million valuation like this. Like people are just sort of throwing money at it. Not that anybody will give that kind of money to me, but where will that innovation come from? Is it like startups and so on? So Bruce, will start with you. Nick will then go to you, and then Sylvia. I mean, maybe depending on how we are, you might be able to sort of bring us home at that sort of point. But yeah. Let me know if you want.
I think what you're saying is correct. I think, when you think about a lot of what can be done with virtual care and telehealth these days, about 4 or 5 years ago, I think I was pitched by ADT, which is the company that does home alarm security systems. And they're like, hey, we do this stuff, we're in people's homes, we wire them up, we have technology, most of the time we're invisible and we're just there, but if we're needed and something comes through, we have, that's our skill set. That's what we do. We monitor, and when something is wrong, we address it, and we have the right expertise, and we contact people, and we have great customer service. And, a lot of, 365 days a year, that's a lot of what healthcare could be, is just somebody keeping an eye and being aware and available at a moment's notice, as opposed to the traditional model of, well, I've had this sort of uncomfortable sensation. I'm going to see if there's a cardiologist who can see me sometime in the next 3 weeks. So yeah, I do think that the day-to-day, yes, and sure, if you are somebody with a serious chronic condition and you need the higher level of, knowledge and availability of expert services and stuff like that, yes, you will not be that person. But most of the population is not that person. Most of the population can get by with really good availability and customer, service.
Yeah. As for where the innovation is going to come from, yeah, there is so much money, so much VC money flowing into startups, and even and there's so many ginormous companies that are also investing in healthcare. It's hard to say. What I'm really excited about, though, is actually a regulatory change that I think is going to unleash a lot of potential for tech in medicine, and that is the 21st Century Cures Act, which is a funny act. The more I read about it, the more like nuggets and stuff I piece out of it. But passed in 2016, actually broad bipartisan support, kind of under the radar, right after the 2016 presidential election. And the implications of this act are still kind of unfolding. And if you talk to a doctor today about 21st Century Cures, they think it just went into effect last week. And that is, in fact, one of the aspects that went into effect, that now notes have to be shared between, like a doctor's note, a provider's note has to appear by default in the patient portal. It's a big change in doctor-patient relationships. Now they can patients can read what their doctor said about them, which is a change for some of us. But another aspect of this act goes into effect next year, and that is this provision about APIs, application programming interfaces, and should make it so much easier to share data from your patient portal to another doctor, to another healthcare system, or to an app or any kind of third party. And I imagine, like, when you get your lab results, when you get your doctor's note, if you want to parse it, if you want to just send it to another service that interprets it for you and kind of spits back an easy to understand, kind of either explains the jargon or even gives you prognostic information. And yes, there are privacy concerns, and there's, just like if Facebook starts offering a service that helps interpret your medical information, I'm not sure how comfortable I'd be with that. But the truth is, though, that like I think it is going to be so easy to share this data, and I think it's going to unleash a lot of new, it's going to help develop a health app economy that really doesn't exist right now.
I love it. Health app economy. I'm taking notes.
I didn't come up with that term. It's actually the head of ONC, the prior head of ONC, Don Rucker, was really hoping that the 21st Century Cures Act kind of brings us into this modern age, because we're doing so many other things via apps. It's a shame that until now, healthcare hasn't been done by apps. And you can't overstate the importance of, not only with telemedicine, like millions of Americans finally done telemedicine in 2020 because of the pandemic, but in 2021, millions of Americans are using their phone to access their vaccine information, their test results. And, you know, this was unheard of adoption from a couple years ago. If you had told me that like 20, 30 million Americans would be checking their phone to see what their test results were, like that, it's mind blowing, but it's now just table stakes.
Nick, one of the companies that I was looking at around the billing space and you know, digital communication with patients is a company called Cedar, and you know they do digital billing. And one of the things that they do is when they provide a bill, they actually take the diagnosis codes and like turn it into regular language so people can understand what they're being billed for. And I think it's really funny because I've been also working in the note space where they, you know, in documentation, where they're using natural language processing to pull out diagnosis codes and everything like that. And so I was talking to Cedar and I was like, what is this, like a natural language processing that you like take medical language and like turn it back into something?
Oh, I'm going to use that. That's good.
Yeah. But yeah, no, I think it's huge because like, you know, one of my family members got sick and their patient portal was like pinging, and this is, they were inpatient and was pinging his spouse, one of my other family members, every time they got a lab set back. And so of course that meant, because then nobody else in my family has a medical background. So that meant that, you know, my other family member was texting me all the time being like, hey, we got these lab values, you know, they're saying some of them are high and low, like what's going on? And so part of me, like, I actually love open notes. I think open notes are fantastic. And like, I wish we'd done it years ago. And I think it creates a much better relationship. But we like started with the wrong things. We're like putting up, imaging analyses and lab values and things like that, and not giving any context for things. And so, we went on this really crazy way when we were talking about communication. Yeah, I mean, I think that there are two options. Either the, disruptors and the traditional healthcare folks start working together, or pieces of traditional healthcare are going to be removed from the health system space. I mean, I think, Bruce, this is kind of what you were talking about, but it's like the lower acuity work is going to be taken up by some of these primary care disruptors. You're going to start moving care out of the hospital and into the home. Again, as a hospitalist, it drove me crazy that I mean, pediatric hospitalist, so like, to be fair, but I would see half of these kids and you're like, oh, okay, great. They're in for cellulitis and getting IV antibiotics twice a day. And then because of that, for the rest of the day, they're like laying in bed. It's like, this doesn't make any sense. Why are we doing this in the hospital? There's a ton of that work that's going to be coming out of the hospital. And then you're going to have health systems that are really just for the absolute most complex, highest acuity patients, and sort of lose the rest of that. And so yeah, either we're going to learn from each other and there's going to be some great kumbaya, or everything's going to split out and you're going to see basically specialization in various areas.
Yeah, thank you. We have about 4 more minutes left, so I'll queue up one other sort of question. And I know there's a few questions around payment and parity and so on and so forth. We'll probably, there's a lot of sort of research sort of out there on that, but just sort of staying with the theme of sort of TeleHealth 2.0, and so apologies to Shannon. Bruce, you mentioned something about that the convenience aspect of things, and I'd like to get all of your ideas, and maybe Bruce will start with you first, and Sylvia, and then sort of Nick. I worry a lot about sort of my industry, and I'll call it sort of traditional sort of healthcare hospital-based industry, because I feel that many of the places that we work with are top-notch, high-quality, A+ institutions, but there is an aspect where convenience will trump some of the perception or need for quality, because if you offer me convenience, I will take a B+ experience over going for an A+ experience, if it's just so complicated. And it's difficult in healthcare because sometimes, you're talking about like real issues. I mean, so if it's say cancer care or, getting your, hip replaced or something else after an accident or something, you want A+ care, but there it's like a moving sort of spectrum. So talk maybe, each of you 30, 45 seconds around convenience trumping almost quality and how that paradigm shift might happen, because that fits into the whole telehealth of the future perspective.
I think in healthcare, the issue is what is good enough and what is acceptable. When I take a picture on my iPhone, the quality isn't as good as if I had a really high-level, high-end digital SLR, but it's good enough in most cases. If the healthcare is convenient and it's good enough so that people are getting overall the right treatment, the right care, the right outcomes, that's going to be the metric that people will go by.
Yeah, another analogy that sorry, was it Sylvia's turn? You don't want me to be the last one to speak anyway. Sylvia has better ways of encapsulating things. But another analogy I like to think about is when you ask someone about their flight or their experience getting from place to place, no one says like, oh yeah, I had a really great pilot. My pilot navigated those currents really well. You kind of, they talk about how cramped the seats were, or the airline food, or the hassles at the airport or something, because that's where the real friction is. And we kind of assume that the pilot is an expert and is handling those aspects. And I think healthcare is sort of heading in the same direction, where we have a basic level of competency and expertise with the medical decision making, and then now there's so much friction around the access and the just getting it, and that's where our attention is really going to be focused.
Yeah, I'm going to say the same thing. It's a false dichotomy. I can have the best diagnostic skills. I can have the most up-to-date protocols. And if I give my patient a treatment plan that they can't follow, then it is all for naught. If I give somebody the latest medication that has the best results in a randomized controlled trial, and it requires refrigeration, and they live in a shelter, it doesn't work. And so, we can talk about, we did amazing care, but my patient just didn't follow it. My patient was non-compliant. That's not how the world works. Like, we need to be providing care that's accessible, that's convenient, that wraps around our patients' lives, instead of expecting that we're going to drop brilliance on people and they're just going to take it and that's going to make them better. So, we want both, and it is necessary to have both if we're really going to improve the health outcomes of everybody in this country.
Thank you. This is spot on. And Nick, you were right. Like, Sylvia just brought it home. And it's right at 9 o'clock. I know people have things to do. Great engagement, because you've done this sort of several times, and having all of you sort of stick around, even people walking through subways and tunnels, getting to this point is great. I want to take a second to thank all our panelists. What a star panel. Sylvia, thank you. Bruce, thank you. Nick, thank you. And look forward to seeing many of you on May 14th when we dive into remote patient monitoring and how that works.
Thanks, guys.
Take care. Bye-bye, guys.
Thank you.